Warm good morning to all of you. Let's start our CVI session. CVI, or cerebral visual impairment, is a dysfunction in the visual function due to malfunction of visual centers or visual pathways in the brain. It is steadily increasing, and in developed countries, now it's considered as one of the commonest cause of childhood blindness. In our country also it's increasing. Our latest advances in neonatology and fetal medicine have improved the surveillance, better surveillance of extremely premature babies, and so this CVI problem is increasing steadily. These children need special evaluation techniques and tailor-made strategies for habilitation. This IC is to throw in light to the problems of CVI children, the clinical features, evaluation and habilitation strategies. So let's welcome Dr. Mallika, Professor of Ophthalmology at Medical College, Trichy, for the first session.
Good morning all. Thank you Dr. Geetha for giving me this wonderful opportunity. And my topic is, what is CVI? By definition, it is the variable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. Why is CVI becoming important in India also? Because it is emerging as one of the commonest causes of visual impairment among children in our country, maybe because of with increased improvement and survival of preterm babies, children affected by brain injury due to perinatal insult, metabolic disorders and trauma. And we will see how does the brain see. We all know that when light falls on the retina, it is converted into electrical stimuli and impulses pass through the optic nerve, optic radiations, and then lateral geniculate body, and then it reaches the occipital cortex. What happens when the image reaches the brain? There are three stations where different processing are taking place. Station 1 is the occipital lobe, second station is the posterior parietal lobe, and third station is the temporal lobe. Let's see the things in detail. And at the occipital cortex, the vision is processed for its visual acuity, color vision, visual field, etc. Very close to the occipital lobe is the middle temporal lobe, which processes the motion process. And the information then passes to the temporal lobe. It is considered as the visual library. So when we happen to see one object, this temporal lobe comes in action. And there are a number of images we acquire throughout our life is stored in this temporal lobe. So when we see an object, it is matched with the images in that library. Then we recognize, oh, this is that person, this is that thing. So this is considered as the library. And this process is a very slow process, and it occurs in an unconscious manner. Then information also passes to the posterior parietal lobe. Posterior parietal lobe, here, suppose we happen to see a number of objects on a table and we want to take a particular thing, for example a pencil, and we have to process a lot of things, and we want to take a particular thing, and that is called visual orientation. That process happens in the posterior parietal lobe. And whenever we want to take up that pencil, lot of things has to come in play. That is, we have to calculate how much distance it requires, and what is the orientation of your fingers. And for this, the posterior parietal lobe comes in action in accordance with the help of motor cortex and the frontal lobe. So there are two streams. One is the dorsal stream that connects the occipital cortex with the posterior parietal lobe and the frontal lobe. And this is otherwise called witH stream, and this is responsible for the location, movement perception and spatial orientation. The second stream is the ventral stream, that is otherwise called witH stream, and it connects the occipital cortex with the temporal lobe, and that is responsible for the color perception, texture, pictorial detail, visual memory, etc. So why are these pathways important? The visual plasticity of a child's brain allows us to stimulate other pathways. Suppose one stream is impaired in one child, we can think of stimulating the other pathways which are not very important. Suppose, for example, the reflex pathways and retinotactile pathway, you can stimulate that, and that can result in improving visual rehabilitation. Visual stimulation can activate other pathways and can allow for an ambulatory vision. So dorsal stream dysfunction will cause difficulty in climbing stairs, trouble walking in uneven surfaces, identification by touch, inaccurate reach, knocking over objects, etc. Whereas ventral stream dysfunction result in a problem with route finding, forgetting where the objects were located, and difficulty in recognizing faces, shapes and objects. So this is a beautiful pictorial representation by Dr. Gurdon, that in the tree of vision, where everything is beautifully pictured, from the occipital cortex to different aspects of processing of vision. And you come to the epidemiology, the incidence of CVI is 36 per 1 lakh in late 1980, and now it has increased to 161 in 1 lakh in 2003 as per the records. In our country also, it is also increasing. This article shows this evidence. It's an article by Dr. Niranjan Behera, that the cerebral visual impairment is a major cause of profound visual impairment in children aged less than 3 years. They also found that the rate of the incidence of this CVI is almost same if you compare the rural and the urban population. If you check the causes of profound visual loss in children, it's in the Western data, and the Indian data show that it is mainly due to CVI. So what are the etiological factors? Hypoxic ischemic injury that happens in the perinatal period. If it happens to the full-term neonates, it will result in watershed infarction of the parieto-occipital or parasagittal area. If it happens to the preterm neonates, it will result in periventricular leukomalacia. Other mechanisms are oxidative and inflammatory damages, which will result in death of immature oligodendrocytes, injury to the subplate neurons that forms connection between the thalamus and the visual cortex. What are the causes? Mainly the head trauma and the congenital CNS infections, mainly the herpes simplex infection, meningitis. And that will result in venous sinus thrombosis or thrombophlebitis, hydrocephalus and hypoxic ischemic insult to the watershed areas. There are certain congenital malformations associated with this thing, like the Chiari malformation, encephalomyelocele hydrocephalus, and this porencephalic cyst, Dandy Walker system, and hydrancephaly. So CVI in late child are due to melas ornithine transamylase deficiency, Fabry's disease, Leigh syndrome, X-linked adrenoleukodystrophy, and respiratory arrest, head injury, complications of cardiac surgery, cardiac arrest, focal infections, status epilepticus, and encephalitis. So to conclude, the eyes just see, but the brain visualizes. The knowledge of complex visual processing in brain helps better understanding of CVI. So every ophthalmologist should have a basic knowledge and awareness of CVI. Thank you so much.
Good afternoon, my dear friends. So CVI actually is a comparatively virgin area of specialty in the ophthalmologic field. And so many attenders here. That's a great thing. Attendees have come to listen to this. Now, we will listen to the next speaker, Dr. Sujeta Namburi from Thrissur Medical College.
Respected seniors and dear friends, I thank KSOS and Dr. Geetha for giving me this opportunity. Cerebral visual impairment is a rather underdiagnosed condition, though it causes marked visual impairment in children. My presentation is aimed to discuss how we can detect or suspect children with cerebral visual impairment in children who are attending the general ophthalmology OP. I'm only mentioning the common general features in my talk. The detailed evaluation and diagnosis will be in the following presentations. So I would like to present the topic under these headings. Cerebral visual impairment should be looked for, as Dr. Mallika said, in all cases of perinatal insults like hypoxic ischemic encephalopathy, periventricular leukomalacia, and hydrocephalus. All children with prematurity, history of intrauterine infections and acquired brain trauma and epilepsy should also be evaluated. Then a detailed history should include all the findings which will tell you whether the child has a stormy postnatal period. Then a structured interview in their own language can be administered to parents so that you can have a complete idea of the visual behavior of the child. It will help you in further assessment. Then we go on to look for certain characteristic visual and behavioral features of cerebral visual impairment. Before that, we should keep in mind that these children may have other developmental and cognitive issues. They may have a normal eye examination, but their visual performance may vary depending upon the time and place where you are examining. And also usually they have a short span of attention. So we go on to look to the usual 10 characteristics of cerebral visual impairment, which we'll discuss later. So all these can be explained by the damage to the wear stream or the what stream, which Dr. Mali has already said. So usually these children will not look at your face. They are uninterested in the surroundings, but they show a particular attraction to bright light, and they have an unpurposeful light gazing phenomenon. They have certain preferred colors, red and yellow usually, and they need movement to obtain attention and sustain it. Usually they are slow to process visual stimuli, like this child who takes her own time to look at the favorite video in the mobile phone. So this is called visual latency. These children have problems in playing with in visually complex scenes. They cannot play with toys like this. And if you are offering a new toy, they are not interested. They like to pay attention to their familiar objects. Most of these children cannot process multiple visual objects in the surroundings. Like this child with CVI, if she is looking at this scene, he or she may be seeing only one part of the scene, like the face of the old man. Actually, what happens is the child will be overwhelmed by the surrounding and will keep his or head down. Then slightly older child is unable to cap the pen after repeated attempts. This may be due to impaired visual guidance of movements, and it's called optic ataxia. Then they may also show lack of perception of orientation, and they cannot match colors or shapes. These children will look away from you when you are talking to them because they cannot process hearing and vision together. and some of them cannot shift their eyes from one object to another, and they turn their heads instead. That is called the oculomotor apraxia. Some children like this boy cannot pick up food from, is not interested, cannot see the food kept in the plate below because of the lower visual impairment. Slightly older children like this will find it difficult to climb downstairs. Then they also have distance viewing problems. Then other interesting features they can have is difficulty in recognition of faces called prosopagnosia. Then they cannot recognize letters, numbers, and even objects. They also have problems in route finding. These are the usual things we should look for in a child with suspected cerebral visual impairment. Then always keep in mind that about 10% or 11% of these children have associated ocular visual impairment. The child with hydrocephalus also had bilateral cataract. Then what is very interesting is that a pattern of atypical visual processing, that problems involved in each child will be unique. No child with CVI is comparable to another. They are unique. Then I would also like to add, if the time permits, to add few red flag signs which you can advise the parents to look for so that they can take medical attention. That is, if no child is not looking at your face, no social smile, not regarding their hands, not reaching out to objects. Then a slightly older child who cannot point fingers when named, who cannot walk steadily, cannot scribble, has feeding problems. A child who cannot climb stairs. All these parents should be worried and they should take attention as soon as possible. So with these things, I would like to conclude by saying most of the cases of cerebral visual impairment are reported very late like this. But if there is increased awareness of CVI characteristics among the general medical fraternity, general ophthalmologists, and also preferably pediatricians, you can pick them early and you can offer optimal management. Thank you.
Thank you, Dr. Sujatha, for that comprehensive talk. Now we move on to the next talk, Diagnosis and Assessment in CVI, by Dr. Geetha, VKP.
Thank you, Dr. Mallika. So now we have heard about CVI, its clinical features. Now we'll see how we can go work up a case of CVI, that is diagnosis and evaluation. In the first visit, first of all you have to establish the diagnosis of CVI. Then do a thorough eye evaluation to look for any treatable ocular causes, because CVI may be associated with ocular problems like congenital cataract, strabismus or refractive errors. So we have to do a eye evaluation. Then third and most important thing is counseling. Do a proper counseling. Like all parents with CVI children, they will be tired of hearing eye is normal, brain is damaged, etc., etc. So in our clinic what we do is we sort of tell them how their child see, what are the visual processing problems of their children. We tell them that if you don't know, you don't understand the processing difficulties of your child, you will not be able to help your child by arranging suitable environment. And we also tell them that you are the person who is going to train your child, and we are just helping you to do the training. And this is done all 24 hours because this is vision therapy. It need not, you need not have any gadgets. You can just have a glass and spoon and a torch, and you can do it in your kitchen. And we just tell them how to infuse vision in daily tasks. And concept of neuroplasticity, that repeated successful vision, memories of vision will encourage the brain. That concept, if you have given to the parents, that will boost up their confidence. So all this sort of counseling, it will make the compliance better. Okay, now how to diagnose? Dr. Sujata mentioned that CVI, how to differentiate CVI from OVI. Eye is normal in CVI, and so all ocular findings will be normal, but visual behavior may vary. The dictum is visual behavior vary from time to time. It may be variable depending on child factors like fatigue, distraction, and environmental factors like visual clutter and familiarity of the object. All this will change the visual outcome of the child. In a crowded environment, the whole vision collapses in the CVI child, and they'll be stressed. History of traumatic perinatal period or perinatal problems will be present. Latency will be prolonged. Usually, visual attention span will be short, and in crowded visual information, there will be difficulty. And light gazing may be normal, and associated motor, sensory, or cognitive difficulties will be present. So, from these criteria, you can make the diagnosis. And like as you all know, CVI is a clinical diagnosis. Imaging will help if present. MRI may show periventricular leukomalacia, that is atrophic dilatation of the lateral ventricles and reduced amount of periventricular white matter around occipital horns and trigone. But a normal MRI cannot rule out CVI because they are and ultrasound of the brain, cystic changes of leukoplakia if seen, leukomalacia if seen. Then VEP can indicate visual acuity and it may be predictive in CVI. And most importantly, it can differentiate CVI from delayed visual maturation. But delayed visual maturation is a retrospective diagnosis. I am not going into the detail because Dr. Samyukta will be talking about delayed visual maturation. The assessment should be a multidisciplinary one, like pediatrician, pediatric neurologist, ophthalmologist, optometrist, physiatrist and physiotherapist, and neuropsychiatrist. All the team should be present, and ideally video documentation should be done during assessment. Ideally, a place where all these are done under one roof, that place is ideal for CVI assessment. Like in our state, in all districts, we have district early intervention centers. So that is a good center for doing CVI workup. This is our CVI clinic. The evaluation should be done in a clutter-free environment. It's not good to do CVI assessment in our busy OPD. Videos. We can examine the child in supine. Suppose if head control is not there, you can do the in supine position. And in some children without visual awareness, you can have a tent. We have a small room in our CVI clinic similar to a tent where we can omit other visual information so that the child will be aware. The first thing is visual acuity. In infants, we can do LIA paddles where the preferential looking is the principal. And in pre-verbal children, in preschool children, you can go for LIA symbols. Then, suppose if the child is above 5, you can go for Snellen charts. Do a good refraction. That's a must in CVI. In CVI, the easiest and most cost-effective intervention is spectacle correction. So please ask the child to go for a refraction, good refraction and spectacle correction. Then dynamic retinoscopy, that is very important because in some studies it is shown that around 50% of cerebral palsy and 80% of Down syndrome children can have lack of accommodation. So if there is lack of accommodation, you should give +3 glasses. Do retinoscopy in the dark room, then show a near illuminated toy, and if this changes from with to against, there is accommodation. But in some children, there will not be any myopic shift. So in such children, they are considered as accommodation lag, and you can give +3 glasses. It will help them a lot. Ocular alignment and motility is important, and anterior and posterior segment evaluation. Sometimes you will get a surprise like this. Here, this was a boy who came in our CVI clinic with lack of eye contact, and when I did a retinal fundus examination, it was a bilateral retinoblastoma. So we would have diagnosed retinoblastoma later, maybe after 6 months when the child comes with leukocoria. But because of early diagnosis, we could save the vision in one eye where the fovea is not affected, and the child is now going to school. And history is very important in CVI. To prevent omission, we are doing a structured inventory. We are giving a structured inventory. Dr. Dutton has invented this, and I have translated to Malayalam. So this basically, this has some around 50 questions, but basically what we want to know is whether the child is independent, whether the child is going to school, whether the child can recognize faces and familiar objects, such things we should be able to know. Then functional vision assessment. Other than visual function assessment, in functional vision assessment, we do it binocularly and to understand how a person uses vision to perform daily tasks of living. That's a dynamic procedure. Then this is facial communication. Facial communication is like all these. I'll come one by one. Go to the child with an silent animated smile and look for the distance at which the child takes cognizance. You can do it with a mirror also, whether the child is recognizing the face. And this is to know the visual sphere of communication. Whatever you are doing, the assessment, you should communicate it to the parents. You should tell the parents that you should do all the communication to the child within this sphere. Otherwise, it will be useless. And LIA gratings, you can do the assessment and compare the grating pad with the parent's finger and tell them the line thickness. Explain the parents the line thickness the child could appreciate compared to that of their fingers, which make them understand the optimal distance for visual communication. You can use puppet faces also because they are more biological. This is a symbol book is done in preschool children. This is for contrast sensitivity, hiding. If the child responds with a social smile, he must have seen the picture. So that is how we do the assessment. This is in here visual acuity is normal, but only contrast is defective. See how difficult it will be for the child to see the faces because human face is low contrast. This is visual field. Some children this is a 15-year-old boy, they are very smart, they will not tell that they can't see. He is saying, I can see. I ask them to touch it and he can't do that. And if the child can stand up and visual acuity is 6/6, more than 6/60, you can do a leg rise test also to assess the inferior fields. Latency and span of visual attention should be assessed. Pursuits and saccades should be assessed. and evidence of blind sight should be taken. Then you go for cognitive visual assessment when the child is normal or near normal and yet has issues with using vision. That is to assess dorsal and ventral stream functions. This is Leah puzzles, as Dr. Sujata has shown. It is this child cannot see. He cannot understand the shapes. So, ventral stream is assessed by whether the child is understanding the shape and color. The way he holds that object and how he fits it into the slot, that is assessed, reflects the dorsal stream. So, both these streams are tested in these tests. This is rectangles, the size of the object is assessed, whether the child can appreciate. Then Marsden's border for parietal lobe. And this is simultanagnosia. Some children, they will not be able to see many objects in the in classroom or in some hall or something like that. So you should keep 10 objects on the table and ask the child whether he can appreciate how many things he can see. Sometimes he may be able to see only 3 to 4 objects. This is optic ataxia. This boy, see the moment he see the object, see there is mid fanning of the fingers, and when he touches, he just closes. This is optic ataxia of upper limb. There is optic ataxia of lower limb also. I think that video is not there. So this is Leah mailbox. He is putting it. See, he is taking tactile clues. He is touching it with the other hand. Eye-hand coordination should be tested, and visual closure, whether he is able to recognize a familiar word or picture when only a small part is seen. This is very important in reading. A child usually has 1/3 of 60 to 80 atypical processing functions. Every child with CVI has their own unique pattern of vision, and our aim is to find and know the limits, staying within them, using alternatives, extend the limit. In low functioning CVI, when the child is not even having visual awareness, what will you do? You cannot assess the vision. See, in such children, we can eliminate the other objects, objects which compete for the vision by surrounding a monochromatic translucent tent. And you show them, which will enhance his attentional capacity and enable him to utilize the limited vision. In such a tent, you show an illuminated toy in dark room with auditory or tactile elements added to it. You can show a ball, illuminated ball with some tactile element and auditory element attached to it. See, this is a monochromatic tent. We have many children there in our clinic who, like, with profound CVI, who don't even have visual awareness. Such children, if kept in this tent, they will be aware of the surroundings. And see this child. This child is not having eye contact. He is facing the face, changing the face. See, I told the mother to talk to the child and keep child's hand over the face of the mother and sing a lullaby or talk or call him. See the difference. Video. I just wanted to show the video, the difference it makes. The child started smiling. Because when the vision is very weak, it has partners as sound and touch. So then it makes a strong stimulus, and it will will be having a lasting visual memory in the child. See, that is the difference. See, ask the child to touch mother's face and illuminate mother's face. Shine a torch. Then the child is smiling. So that is the entry point. Actually, child is not having a visual awareness. So in such a world, child is just having a visual curiosity, and he'll be aware of the surroundings. Then slowly the visual discrimination will start. This is a success story. Actually, this child was a profound CVI with congenital ESO. So like that we started with the tent and this multimodal stimulation, and we advised squint surgery. They didn't go, as you all know, they'll be very fearful about the surgery, and at the age of 2, this child had undergone squint surgery, and see how smart she is. And the mother and grandmother both were really persistent, and actually they should get a reward. And actually the reward is here. They have a smart kid. All this the mother is always doing. They'll do the training and take a video and send to me. It's like that. So one word about visual intervention. It is not a passive thing. It's a dynamic and interactive thing. It should be carried out within the context of major developmental activities like communication, movement, play and learning. Child needs support to recruit and use visual system at this stage, because this does not come naturally. So that is the message I have to give. So we all get such children, so please do that intervention at the right moment. There are 2 challenges. Helping the child to use available vision creates visual awareness first, visual curiosity, visual interest and visual discrimination. And then help the child to understand what is seen. That is also requires effort, constant interpretation. Always remember about the right to learn, right to independence and right to effective social interaction. CVI can be very disabling but trainable. With the right training at the right time, their skills can be enhanced. At this stage, I would like to express my sincere gratitude to the pioneers in CVI, Dr. Gordon Dutton and Leah Haivanan, for their constant support in our CVI activities. And I thank KSOS and Team Drishti for giving this wonderful platform for CVI.
Thank you, Dr. Geetha. That was a very structured talk. We should really appreciate Dr. Geetha. She has set up a CVI clinic in a government setup, and at Palakkad District Hospital, she is running a CVI clinic very efficiently. It's a good applause to her. Next, we will see delayed visual maturation, the main differential diagnosis. Over to you, Dr. Samyukta Sadashivan.
Thank you, KSOS. Thank you, Geetha Madam. Thank you, Mallika Madam, for this opportunity. Beginning from where she stopped, I'll be showing some light on this differential diagnosis called delayed visual maturation. So for an infant to give a normal response to a visual stimulus, proper coordination between motor, sensory and attentional mechanisms is a must. This is probably how the visual perception of a baby matures from the newborn to the adult phase. Now, the concept of visual maturation is important because proper visual development designs the child's emotional and cognitive development. These are the different visual milestones. Blink response to bright light can be elicited within a few days of birth. Pupillary reflex can be elicited after as early as 31 weeks of gestation. The child should be able to make and maintain eye contact by 6 to 8 weeks. In 3 or 4 months, the eye should be orthophoric. Foveal maturation and accommodation appropriate to target should be seen by 4 months, and macula maturation expected in 15 months. So we give some allowance for premature infants, and we cannot say an exact week-to-week correlation as to when a premature infant would attain these milestones. Disconjugate eye movements, skew deviation and sun setting may sometimes be seen in healthy infants also. but exercise caution when they persist beyond 3 months. These are the signs of poor vision development. And 5 important functions already told by Sujata madam. These are easily observable and they help us to pick up any delay in reaching the visual milestones. Number 1, visual communication. Any delay manifests as a failing eye contact. By 8 weeks of age, an infant should be able to communicate with both parents in turn. Lively communication with social smile normally develops in the 3rd month. Look for any delay. Awareness of hands and hand regard, again in the 3rd month. Goal-directed hand-arm movements for reaching and grasping, observed in the 5th or 6th month. Recognition of facial features establishes by 7th and 10th month. So infants at risk of delayed visual development, like those with Down syndrome and hypotonic infants, all of them require periodic screening, and early and then periodic screening. So delayed visual maturation, the defining characteristic is the inability to fix and follow. The characteristic is that it improves by 4 to 6 months of age without any treatment, sometimes overnight. Some children may take up to 12 months for complete resolution. So it's basically a retrospective diagnosis. So first described by Witch in 1920, this was defined as a temporary visual inattention problem. A child with isolated DVM is a source of constant worry to the parents because the child would appear blind, unable to focus attention, won't be able to fixate or follow anything in the visual world. Subsequent improvement appears by 6 months of age. So these are the salient features. Normal ocular, neurologic, electrophysiology tests all would appear normal. Imaging results would be normal. Central eye movements would be normal. VOR would be preserved, vestibulo-ocular reflex. So these imply that the anterior and posterior sensory pathways as well as the cortical motor pathways are intact in DVM. So these are the suggested etiology. One is possible delay in myelination of the optic nerve, immaturity of the visual association area, a defect in the subcortical extrageniculostriate visual system in the infants, delayed development of the top-down attention center network. It is primarily thought to be a subcortical problem which has its impact in the emergence of cortically mediated responses. So this is how classification of DVM has been done. Type 1 is isolated DVM, no other abnormality. Type 2 has residual neurologic abnormalities. Type 3 means association with congenital nystagmus and albinism. And type 4 means associated severe ocular abnormalities. So isolated DVM is R differential to CVI. It is characterized by absence of any detectable ocular and neurologic abnormalities and rapid resolution of symptoms by 6 months. And during this initial phase of deficient fixation and following movements, patient may have a transient exodeviation also. Fundus may show a grayish colored optic disc and the ERG VOR responses would be normal. Saccadic eye movements would be absent when fixing following movements are defective. Later on, as fixation gets established, these things will improve. So again, believed to be a primary visual inattention disorder. Diagnosis is confirmed after symptoms resolve and other disorders are excluded. So they may look alike. CVI and DVM may look alike. Vision will improve to normal in DVM. In CVI, vision can improve but never to normal. And of course, there is an underlying neurological problem that explains the abnormal vision. So Treseder et al. Has timed the resolution of symptoms in DVM. Each group takes different times for resolution of visual inattention. Type 1 shows complete return to normalcy. These are the differential diagnosis for isolated DVM. So to differentiate between DVM and CVI, seizures, they are possible but not likely in DVM type 1, likely to be present in CVI. MRI, VEP, OKN responses are normal in isolated DVM. They are abnormal or impaired in CVI. So to approach such a case, always remember DVM is a diagnosis of exclusion. Careful ophthalmic examination and refraction are mandated. To differentiate between the two, go for a neuroimaging. So when it comes to parental counseling, emphasize multidisciplinary approach between ophthalmologist and pediatrician. And in a case of isolated DVM, the parents can be reassured that the prognosis is good for the child's future visual acuity. Regular pediatrician reviews should be advised. So we can identify, we can be aware of this particular entity called DVM. Early identification and management can be made feasible by connecting vision with other developmental milestones. There is this thing called MCP card, Mother and Child Protection Card, issued by the RBSK, which shows a direct correlation between vision along with other developmental milestones. With that I conclude. Thank you.
Let's invite our guest faculty from Aravind, Madurai, that is Dr. Sahitya, for the keynote address, intervention, CVI intervention in recent technology-driven strategies. She is passionate about CVI vision rehabilitation, and so the ideal speaker. So let's invite her.
Thank you, ma'am. Good afternoon, everyone. It's an absolute honor and pleasure to be here at KSOS, and thank you, Team Drishti and the IC team for such a wonderful opportunity. So today I'll be talking on vision rehabilitation intervention strategies in CVI, the basic concepts and the recent advances. So this slide has already been shown. This is the Western data as compared to the Indian data. So both data show that a 26% or 1/4 of visual impairment in children between 0 to 3 years is attributed to cerebral visual impairment, only followed by ROP. So this is the largest cause of vision impairment in children under 3 years of age. However, you will not see this diagnosis anywhere in visual impairment category at all. This is almost a hidden disability till date. A child with CVI or vision impairment as early as 0 to 3 years means is going to be developmentally delayed across all domains. What starts as one functional vision impairment is going to progress on to a global developmental delay, leaving a mentally, emotionally and a socially crippled child. This is why diagnosis and timely intervention of CVI becomes important. And we always keep using the term rehabilitation, right? Rehabilitation means you recover a lost ability. However, most of these children with cerebral visual impairment do not develop an ability at all. So what you do is you habilitate, you help them develop an ability. So how early and how impaired? How long are we going to wait to look and treat for CVI? A child who's not fixing to a mother's face at 3 months, start intervention early. They may be associated with ocular vision impairment as well. You might have a bad retina, you might have a stage 5 ROP. Whatever it is, give the child a chance at vision stimulation. Vision impairment or structural vision impairment does not mean that you're not going to have a functional vision impairment as well. Just like you're going to have a superanded amblyopia over a vision impairment, CVI can also coexist with early profound VI or severe visual impairment. So every child you see with vision impairment or functional vision impairment, give them a chance at vision stimulation very early on in life. Even if you get an ambulatory vision, perception of light, that itself can be a start and will give a better quality of light than being completely blind. And for standard ocular treatment, try glasses first. Please do not refrain from giving glasses to a child with special needs. Do not think that they will not wear. They have a much better compliance as compared to children who are typically developing. Even small errors, small corrections, small cylinders, small spheres, they will make a large difference when you prescribe a spectacle to these children, because it helps with the clarity, it helps with the contrast. Sometimes it does help with magnification as well, and you will see a lot of deviant behavior is done away with once the child starts wearing spectacles. Next thing is this one where they had told you about accommodation. Ma'am had already mentioned about this accommodation. You see this child, I'm showing her a very bright red, larger object very close to face, and she's not picking it up. She actually had a lag of accommodation. With a +2 glass that she's wearing, she's able to reach out very well. So this is very common in children with CVI. You will have to look for a lag of accommodation. The most common technique that you can use is a dynamic retinoscopy, where you fix at distance, do a dry retinoscopy, fix at near, do a dry retinoscopy, you have to see a myopic shift. If that also is not possible, do a dry retinoscopy, give a cycloplegic, see the cycloplegic refraction and see if there is a accommodation that's recruited. At least half or 3/4 of your lag should be corrected with bifocals or with single vision near spectacles. Sometimes in children with autism spectrum disorders or ADHD, you might have a lead of accommodation, in which cases a binocular vision therapy might be indicated. And multiple protocols are in place. So the point here is, every time you see a CVI child, do not randomly pick and choose clinical features or tests to write. Always have a standard protocol which you are going to go through, and age appropriate tests should be conducted. And some basic concepts in core intervention strategies for CVI. As for CVI, the detection is difficult, the timing is always off, but the intervention is fairly simple. So most of the time it's environmental modifications, and these environmental modifications go a very long way. The only problem here is it has to be customized to each child. So it goes by 3 Ds. This is a very basic overview. By the developmental level of the child, meaning how much vision, how much communicable vision the child has, what is a contrast, what is a field awareness, and etc. Or the developmental milestones, visual milestones that the child has achieved, the diversity of vision stimulation, and the duration. So developmental, a few examples here. So as you can see, you have to look at the contrast. Always give a high contrast object so that a child is able to pick up. And here they are switching contrast. These are custom made tables where you can give black on white or white on black contrast pictures. If the vision is even poorer, you can try a light box technique, where you can put your objects on the light box and then start vision stimulation. This is one case scenario that I want to show. So this is a 6-year-old male child with hydrocephalus. He had impaired hearing as well, status post VP shunt, hemiparesis, seizures, so many problems associated, and he was studying in special school. This special school that he was studying is a government integrated special school. So eventually the teacher said that he's not able to see, put him in a blind school. But then the parents came to us telling he walks around, he does most of his work, but then they tell that he can't see. So if you can see, the minute we are showing it in the upper quadrant, he was able to see. So then we realized that this unshaded quadrant is the only place where he was able to see. The rest of it was, he was not able to see. Rest of it was a relative visual field defect area. That is why every time the teacher said he's not seeing anything, not seeing anything. But the problem was only in this one quadrant he was able to see. He had poor contrast, only one eye had functional vision, and both eye pale disc. All that we had to do for this child was make him sit on the floor in the class. That was all that was required. He was able to continue in the same school, and we had made a little changes with his writing material, high contrast and everything. So if this had not been identified, would have gone to a blind school. This is how easy it is to treat a child with CVI. So always when you see that there is a preferred retinal locus or there is a preferred area of visual field that the child is using, teach them to use that area to present all your visual stimuli. Slowly we had to train him for mobility also. Like you can see, the whole inferior field he was not able to see, and he was severely hearing impaired. So your routine cane training wouldn't work. If you can see here, the trainer is actually putting his feet over hers and is walking and training him to walk. Now he walks very well with a white cane. He is going to 8th grade right now. When he came to us, he was in 3rd grade. So this is how the development works. Both for children with severe visual impairment as well as for children with CVI, mobility becomes very important. So for very young children under 1 year of age, your routine native walkers which you would give any typical child, encourage them to walk with that. Slightly older children with strollers, sometimes inferior field defects, you can use high contrast shoes or lighted shoes, because these are all relative defects. If you increase the stimulus intensity, they will learn to see. Slightly older children, height based canes. And the diversity of vision stimulation, always give one colored object. Do not crowd or give multiple colors and multiple borders that the child will get confused with. Keep the background as neutral as possible. Simplify the visual array, meaning even when you're testing, show only one thing at a time. That is why single optotype visual acuity becomes very important in every child with special needs. And sometimes for children with simultanagnosia, what they'll do is approach magnification. They'll just go very close to the object and see. This is why many children with special needs will go very close to the TV. They will think that vision is not good, vision is not good. It may be a coping mechanism to simultanagnosia. They go very close, the other things get blocked out, they will see only what they want to see. Sometimes they adopt large face turns so that the central visual acuity is blocked out, and peripherally they will see only that limited visual stimuli. So these may be coping mechanisms to simultanagnosia. If they work, it's better to leave the child. And sometimes when you do Ishihara testing, these children will not recognize colors. That is also because of the simultanagnosia only. When you have multiple dots and a child with crowding will start seeing the individual dots and will lose out on the bigger picture. That's why when you check Ishihara, they might fail Ishihara testing. So such children, even while reading, you can give such typoscopes. You can see that the whole area is blocked out with only a single slot. So only that one line will be there and they can start reading with that. At school, environmental modifications at school become very, very important. Can you see this writing with the pencil? So if a child with poor contrast is going to write with your routine HP pencil, he will absolutely see nothing. Whereas if you give a darker pencil or a marker, then even with poor contrast, he'll end up seeing something. So always change their writing material, change their notebooks, give them boxed notebooks where they can write one letter in one box. Make sure they are seated at the right distance at the blackboard. Make sure there is no glare, or if they need extra illumination, they should be seated as such. Line spacers and typoscopes can come in handy. And also, many of these children have trouble with facial expressions, especially children with autism. So these expressions should be taught. All these expressions should be taught, what they mean and how they behave. Duration, give them adequate duration to respond to a stimulus. Don't just keep flipping cards. They will not be able to see. Give them at least, sometimes they take even 30 to 40 seconds to literally move their face and come. Now moving on to technological advances. So this is one Android application that's in-house prepared in Arvind. So this app is called Vikas Visual Intervention Kit with Analytics for Special Needs Children. This has 10 major exercises which are visual milestones camouflaged or designed as simple games for children. It has an execution phase and a training phase. So whenever you want to test a child, you can put on the training phase, execution phase, and ask them to play the games. Whereas if you want to train the child, you have the exercise mode. So once you do full assessment, you see where the child lacks, and that particular visual capacity you can help the child train. The mother or the special educator, whoever is at home, can train, and when they come back to you, you can reassess the child. This is freely downloadable. And next, coming to ambient lenses. Whenever children have optic ataxias, poor balance and grasp, sometimes yoke prisms come in handy. Yoke prisms are prisms of same power oriented in the similar direction. You see this boy with PVL, he has difficulty climbing down stairs. He actually had an inferior field defect as well. Once we put him on yoke prisms, his walking has improved, balance has improved, and he also negotiates obstacles well. So similarly, this child with CP and CVI, you can see her grasp is very poor. She'll come very close to the object and pick it up. With yoke prisms, see how her grasp improves and how she maintains good posture. These prisms are, however, weanable. So once the brain has learned how to do it, you can actually wean them out of it. Another technology improvement is this special software or NVDA training. It's a non-visual desktop access where we train these children to learn computers. If they can't write, don't push them to write. It's okay, put them to computers. You'll be amazed at how smart they are and how early they learn computers. So this boy had poor vision also with CVI characteristics, autism characteristics as well. So if you see him now, he's trained with NVDA. He goes to school with NVDA only. So these children who are a little good enough with hand-eye coordination are able to type on a keyboard, we train them with NVDA as well, so that they don't have to write and go fall on their books and try writing. Even children with CP whose fine motor is not so great, you can still train them in NVDA softwares and switch them over to computers. Now a recent advance is a smart vision glass. It's a wearable device incorporating artificial intelligence and machine vision learning. So there is a small chip here. I'll show you the video. What this does is it recognizes objects. There is an object identification mode. There is a face recognition mode. It can read out for you. It supports all Indian languages. It also supports handwritten material. There is a navigation mode where it will alert you about obstacles. So this also we've been using in children with special needs who cannot identify faces or who are not able to walk or who are not able to read. Also for blind people also this is useful. So I'll just show you the video. Do we have an audio? No, no audio. Okay, it's not there. So I'll just tell you this SVG, this is wearable. It has a small chip like this and it has multiple buttons on the side. So each button is one mode. So this is the reading mode where it will read out for you, and this is the object identification mode. If you just tap on the mode, it will tell there is a desktop in front of you. There's no audio which is coming, so you're not able to hear what it's telling. Similarly, you can also use it for navigation. It will alert you on the obstacle, saying there's a ½ meter obstacle, there's an obstacle at 1 meter. This is a face recognition mode, which will tell that there is one person, a male person sitting in front of you, approximately middle-aged. Sometimes it can also recognize emotions. It can tell there's a person smiling in front of you. If there are 2 or more people, it will tell there are 2 or more people in front of you. So this is a recent advance that has come, and now you can see this boy with he's a CVI with posterior parietal lobe dysfunction. So he's holding the reading material and it is reading it out for him. So here you can see him using it for object identification. Actually it says there is a plastic bottle in front of you. So now these children, when the CVI is not very trainable or the vision is not improving, then you can also switch them over to this. Their quality of life is better and it makes them independent as well. Another device that we use is U-Read. If children have only reading difficulty or severe simultanagnosia and they're not able to read properly, this is a machine that will read it out for them. You can just put the book underneath, it will read it out, it will pause, it will also save what it has read. They can come and access it later. This also supports nearly 6 to 7 Indian languages, including Tamil, Malayalam, Hindi. And a very recent advance now that has come is this virtual reality augmented therapy. We have always done this in-office and online therapy here, but now this virtual reality box has come in. So this has all these games for hand-eye coordination, training saccades and pursuits, stereopsis. It is also used as amblyopia therapy. So for children who are not very claustrophobic or for whom I can put this VR box on their heads, this therapy also we are giving for CVI. Now this child, as you can see, she doesn't have a very good hand-eye coordination. So she's only doing it with her head. She can just move her head. So the game she's playing is this ping pong ball game. It has a ball that will come and the child has to hit it with her head. She moves her head, the ball will hit. So this is more for training her for saccades pursuits as well as for coordination. For attention and coordination. If a child is good enough with fine motor, they can use the joystick itself and start playing. So 20 minutes of this therapy is also being instituted now. This works very well for all their basic visual capacities. One problem that you have to note is you have to make the background very clear. It cannot be crowded. You can change the background, you can change grayscale and also contrast. Make sure that if children have seizures, you don't put them for a very long time in this. So this is the online vision therapy that we do in our, after COVID we just started this. So for children who cannot come to the hospital every single time, we put the mother at home and there is a special educator who will over Zoom platform, she tells what to do and the child does it.
cheeks രണ്ട് കാപ്പ്.
Now last is a cross referral. Everybody says that put it all under one roof. You have all therapies under one roof. That is very ideal for a CVI clinic. I've tried it for 3 years. I've fought for it, but of course I didn't get. This is not because of the vengeance that I did not get, but finally I realized that your management also is not going to give you all under one roof. Being eye hospital, you're not going to get physiotherapists and everybody under one roof. And not every time your child is going to come back to you to the same physiotherapist, to the same occupational therapist. Children are coming from elsewhere. So what we realized is decentralize this whole approach. Put the child in focus, bring all therapies to the child. What we do is when we do the vision therapy, we connect over the physiotherapist or occupational therapist on Zoom platform. So they see what we do. They also integrate their own visual tasks with us. If we are not able to get the child with us, when the physiotherapist is performing, we connect over online. So at least we know what the child is getting. And if we can alter their exercises, we can infuse a visual task in their exercises, it helps the child improve. So wherever the child is, at least the child gets all therapies with their preferred therapist and not with our therapist. That is what we were trying to do, and this showed us that it has a increased compliance. And always remember that the reverse is also true. Your child does not have CVA, but your child has early on blindism or profound visual impairment. If this does not take blind rehabilitation fast, this will present as autism later. It is called blindism. If blind rehab is not instituted early, you will end up with a CVA cross disability as well. So thank you very much for the opportunity, and there is no greater disability than the inability to see a person as more. Do not think that these children cannot perform. Give them and they'll amaze you. So please do a right timely referral and identify this early. Thank you for the opportunity.
Thank you. That was a great talk. I invite Agustin sir to give a memento to Dr. Sahithya.
No, I got really congratulating Aravind Madurai for the wonderful work. You know how difficult it is to rehabilitate. And you cannot get a full vision also. Not even at least half of 50%, you won't be able to get it, right? The problem is that only ophthalmologists cannot tackle this thing. Pediatricians, especially the neonatologists. As you have rightly pointed out, it has to be picked up. Not a social smile coming between 3 to 4 months' time, but a light reflex, even at the 1 month or 2 weeks old child, will pick up something. And most of the pediatricians should be educated for that. I mean, they should be informed. And then ophthalmologists also should be able to refer to the higher center like yours, how to tackle it. Thank you very much everybody for listening to this. It's a virgin area. Not fully you are able to recover every child, but a lot of advances has been done in this field. So thank you all.